Today I'll be presenting a case study for chronic pain. It will include history, physical exam, image review, differential diagnosis, and treatment approach.
The patient
is Paul. He's a 65-year-old male. He has a history of chronic right neck, mid-back, under scapula, and low back and hip pain.
Our patient today is
It's
Paul.
described as constant and severe
male.
to these areas.
He
shows
shows
up
up
today
with
requesting relief for his
chronic
pain.
right neck.
He says it
mid-back,
interferes with lifting and
low
sleep.
back and hip pain. He describes the pain as constant and severe to these areas. He's requesting relief for his pain, and it interferes with lifting and sleep.
His primary medical history is significant for depression and anxiety, chronic knee osteoarthritis bilateral, chronic gluteal and low back pain, chronic neck pain. He is a recovering alcoholic. He's been sober since 2009. Reflux disease, COPD, migraine headaches, hepatitis, high cholesterol, and he did sustain a neck fracture back in 1997. His primary surgical history and current and past treatments he has tried include a left knee surgery. He did have neck surgery in 2006, hemorrhoidectomy, and treatments have included chiropractic care, previous injections, TENS unit, neck traction, whirlpool, stretching, and use of a crazy cane for muscle knots. His social history is kind of significant for depression and potentially some PTSD red flags. He is a Marine veteran. He's widowed, lives alone. He is on disability. He did attend some college. To his benefit, he has quit smoking 2 months ago. He is a recovering alcoholic, as noted, since 2009, but he does not attend any meetings. He does admit to marijuana use and past history of cocaine. He does his own therapy exercises. He did have a suicide attempt in 2008. As far as ADLs, he does drive. He takes care of self and home. He carries his laundry and groceries. He does report that sleep has been slightly better, but still is interrupted by pain and thinking or anxiety. His main complaints are for pain he describes as bilateral, lateral posterior neck with radiation to right periscapular area, to mid perispinal, thoracic, and low back. He does still have the bilateral knee pain. Does state the left's worse than the right. The pain is burning, feels a rubbery feeling, and occasionally the right knee does give out on him. He reports numbness, tingly at times to his right knee, neck, back, and hands. It's made worse by driving, sitting, standing, walking in prolonged positions. Decreased by lying down, cold, heat, TENS, and changing position and massage. His physical exam and medication. Paul is appropriate weight. He is neatly groomed and pleasant. Review of system is negative for eyes, ears, nose, throat, respiratory, cardiovascular. Musculoskeletal is negative. Walks with a normal gait. Observation of his spine, ribs, pelvis, they are aligned without deformity. Right and left upper extremities have normal strength, range of motion, no tenderness or joint enlargement. He is noted to have a forward head position. Mental status normal. He's appropriate for mood, affect, and he is cooperative. Current medications include gabapentin. Not sure if this is helping. Naproxen, which he says does help his knees, and methadone, which he's been on for a while. 15 milligrams, but doesn't feel like that is helping. Before proceeding, I did want to clarify the neuro exam. The posterior right neck and periscapular area for Paul was painful to palpitation, and also apologize I was not able to download the image for review. It was that of a cervical sagittal MRI view. Did show severe cervical degeneration, degenerative disc disease. He had very limited height between the vertebrae. End plate changes included osteophyte formation. He also had bulging discs, both anterior and posterior, at multiple levels. He did have loss of normal cervical lordosis. I did not note any shifting of vertebrae. Additional information I would want to receive from Paul would be a more complete report on his cervical surgery he had in the past,
what types of injections and what worked for him in the past also. A little bit closer review of his MRI findings, looking a little bit more at the axial views, looking at the neuroforamina and facet joints, also potentially some electrophysiology studies, particularly the upper extremities because of some numbness and some changes in reflexes. And also I'd want to discuss with Paul where he's at with his depression, anxiety, socialization, and may include some spiritual aspects also. Paul's primary diagnosis is that of myofascial pain syndrome to his neck, back area. He did demonstrate multiple trigger points, taunt bands throughout that area. The trigger points were in individual muscle groups, and they did follow reproducible patterns. The pathology for trigger point formation is that of a weak or overused muscle, and usually part of a major muscle group, and quite often is related to an underlying pathology. Differential diagnosis for Paul would be that of fibromyalgia. Myofascial pain syndrome and fibromyalgia have some overlap. Paul did not present with some of the other comorbid manifestations typical for this would be fatigue, cognitive insecurity, some bowel and bladder issues, and also his tender areas were not on insertion sites and were not generalized to his whole body, just to his back and neck. Also, other consideration would be cervical facet syndrome or cervical radiculitis because of some referred pain. Also some radicular symptoms down the arms with some loss of motor in the hands, and also palpitation over the facets bilaterally. The other diagnosis potentially would be cervical myelopathy. Not quite sure on that one for him. He did, because of MRI findings, multiple areas of spinal cord compression, but he didn't present with the typical electric shock or the clumsiness, coordination problems of hands or feet. Treatment plan for Paul would be for trigger point injections. He has multiple, may take several sittings to address all of them. Also important for Paul would be PT to address his head forward position, which is putting the strain on the muscles causing the trigger points, and also includes some stretching, massage, and some posture correction. Also send Paul probably for some a little further psychology referral, some cognitive behavior therapy, and a little bit closer evaluation of his sleep, his depression, and anxiety. Also, he does have the secondary diagnosis of knee osteoarthritis, and maybe some issues with his low back. We'd have to look a little bit closer at that in the future. But as far as his knees, discussion of ways to may possibly improve with a little bit better anti-inflammatory use other than just the naproxen, use of intra-articular steroids, hyaluronic acid, or potentially some genicular nerve. Also, other treatments, get Paul moving into some regular exercise, try to highlight more of a group type for him just because of his kind of socialization, isolation. He may benefit from low impact because of his degenerative change to his knees and back, such as water aerobics or yoga. Medication management, I'd continue him on gabapentin, maybe look at upping his dose, see where he's at. Continue the naproxen, or maybe discuss some other anti-inflammatories, Tylenol. The methadone I would not change at this point until we get a little bit better control of his pain and sleep. I would add some low dose TCAs, either nortriptyline or amitriptyline, maybe at bedtime, and this can maybe help with depression and possibly improve some pain control in the future and also his sleep. And then also some over-the-counter supplements of glucosamine chondroitin for his knees, and maybe some also topicals. Plan B for Paul, once he comes back, we'd evaluate him for his trigger point, see where he's at with that, his pain level, how he's sleeping at night. assess the effectiveness of the other therapies, psychology, PT, exercise. Maybe have a chance now to have some further radiologic studies, old films of his neck back, some reports back from surgery. And then at that time, potentially discuss some cervical facet joint injections, potentially a cervical epidural, or knee injections, all that based on his further physical exam and imaging. And then also review medications, since we added some medications, see the effectiveness and how he's tolerating that. In summary, Paul presents with a pretty complex pain presentation. He has multiple pain generators. He shows up with a desire to get a little bit better control of his pain, especially so that he can sleep at night and take care of himself a little bit better during the day. I believe these goals are realistic. Maybe if we focus a little bit better on medication management, try some new things, and improve his conditioning and posture with physical therapy and get him moving again. Positive observations for Paul is that he's maintained sobriety and recently quit smoking. These are all positives, demonstrating a desire that he has to improve his health. And we probably provide and have some discussion regarding some alternative modalities, since he is in a chronic pain situation, and include socialization, increases physical activity, and then importantly addressing his comorbid findings of depression, anxiety, and insomnia to hopefully have better pain coping.